Okay, so today we are going to discuss the post-operative pain management. You are SHO on call attending a post-gastrectomy patient for a post-op pain. While reviewing drug received only Panadol and Coxia. It's like Ricocep COX-2 inhibitor, selective COX-2 inhibitor. You are called to the ward after a patient who underwent uneventful THR, total hip replacement, is complaining of pain. The patient is on PRN, paracetamol, diclofenac, and oromorph. So, define pain: unpleasant sensory and emotional experience associated with actual or potential damage. So, unpleasant sensory and emotional experience. Sensory and emotional experience, these are the two components associated with actual or potential tissue damage. Actual or potential tissue damage. What to do after seeing this drug chart? Investigate why PRN medication were not given. Prurinata when required. File an incident report. So, PRN, paracetamol, diclofenac, and oromorph. So these are the drugs which are which when the person is feeling pain or when required, so you give it. So yes, most painkillers we prescribe it this way for mild painful conditions, but here the patient is underwent THR, and now they have shown you the chart, and chart shows that the Prurinata, paracetamol, diclofenac, and oromorph are not given. So you have to file an incident report. How will you manage this patient after this drug chart? Immediate management in this critically ill patient in pain. Patient assessment is vital. It should follow the same crisp system of assessment as in other circumstance. Okay, so before going into the depth of this condition or this whatever, recently in UK and one center, I think in Edinburgh, there was a new station of examination of this chest rib fracture patient, and you have to examine the patient and assessment and then management. So this can be applied to the same condition, or this is the related to this station. So you have to go through A, B, C, D, E as we do normally. Universal CRISP protocol. Start at the beginning by checking that the patient has a patent airway, check respiratory rate, pattern, and depth of breathing. So this will also tell you about the level of pain as well, because in a very painful condition, patient cannot breathe as well. They hold their breath because of the pain. Is your patient respiratory function impaired by inadequate analgesia? Can he or she cough and expectorate properly to avoid problems later? So such patients can go into pneumonia, basal disease, etc. Respiratory problems. So circulation tachycardia should not automatically be assumed to be caused by pain. There is commonly an underlying cause. Persistent tachycardia or hypertension caused by inadequate analgesia may potentiate the development of myocardial ischemia, particularly in the patient who is already hypoxemic. This is also dangerous in patients which have already some kind of cardiac issue. So in such patients you have to be very careful. Disability: it is important to assess whether the method of analgesia is contributing to a patient's clinical deterioration. Particular attention should be paid to the patient level of consciousness, as decreasing conscious level is an early indicator of opioid toxicity. Full patient assessment. Chart review: if the pain relief is felt to be contributing To the patient deterioration, the drug chart should be reviewed with the following questions in mind. Is effective analgesia prescribed? Is effective analgesia being given? Is the treatment appropriate for this patient? History and systemic examination. History should be obtained using a Socrates method for pain. Site of pain, onset, character, radiation, aggravating relieving factors, and timing, exacerbating, and associated factors. Decide and plan if pain relief is adequate and the patient is improving, then continue and review. If pain relief is inadequate, determine why. Is it due to failure of the method of analgesia? Is it due to incorrect implementation of the method chosen? Is it due to development of surgical complication? Lies with acute pain multidisciplinary team. Acute pain services. Multidisciplinary acute pain team consists of surgeon, anesthetics, nursing staff, and pharmacists. Sign and symptoms of post-operative pain at bedside: crying, poor feeding and fluid intake, shallow respiration, restlessness, sleeplessness, agitated and lethargic patient. Examination: there might be tachycardia, hypertension, and difficult breathing. What are the side effects of opioids? So, adverse effects of opioids due to acute use, adverse effects of opioids due to chronic use. So, acute nausea, vomiting, respiratory depression, pruritus due to histamine release, constipation, urinary retention, decreased level of consciousness, myoclonus, and seizures. Chronic hypogonadism, immunosuppression, increased feeding, increased growth hormone, withdrawal effects, tolerance, dependence, abuse, addiction, and hyperalgesia. How will you measure pain? How to assess pain? Conventional pain scoring systems. Verbal descriptor scale. So, is your pain nil, absent, 1, mild? Is your pain nil or absent is 0. 1 is for mild to discomforting, 3 is for distressing, and 4 is excruciating. Verbal numerical rating scale. So, which number describes your pain? 0, no pain, 10, worst imaginable. And visual analog scale. Visual analog scale was no pain, no worst imaginable. No pain, no worst imaginable. Wong-Baker faces for children. Functional assessment: can you move, can you cough? So this will be the functional assessment. So this is the pain assessment actually. This is scale, not at all severe and extremely severe. So these are different scales which were developed. Wong-Baker faces, so pain rating scale. So this is happy face, happy, hurts but little, hurts little more, hurts even more, hurts whole lot, hurt worse, and then comes the doctors. So these are the different scales. Okay, describe the pain pathway. Pain is transmitted through fast A delta fibers, sharp pain, and slower C fiber, dull pain. So pain can be sharp and pain can be dull. So dull is through C. You can say it like CD. So C fibers, dull pain, and sharp is A fibers. So these are present in the lateral spinal thalamic tract, and then to the thalamus. Thalamus is a relay station for every sensory fiber except the smell olfactory fiber. Olfactory fibers goes directly into the olfactory area. Rest of the other all sensory pathways relay in the thalamus. So this is your pain. This comes here in the lateral spinothalamic tract with first order neurons, and then with the second order they cross. And here we have the interneurons as well. Interneurons, and then they cross and then go up on the opposite side into the thalamus and then to the cerebral cortex. So this is the lateral spinothalamic tract. Ascending tract carrying sensory information from peripheral receptors to the cerebral cortex. Dorsal column pathway mediates touch, vibratory sense, and proprioception. Sensory fibers ascend apically through the spinal dorsal columns to medullary gracilis. Yes, so dorsal column they go and then they cross at the level of these medulla, whereas these spinothalamic tracts they cross at the level at initial level. So we have these spinal dorsal columns to medullary gracilis and cuneate nuclei. From there, the fiber cross midline and ascend in the medial lemniscus pathway to contralateral thalamic ventral posterior lateral VPL, ventro posterior lateral thalamus, and then to the primary somatosensory cortex. Ventrolateral spinothalamic tract mediates pain and temperature. What they do? Pain and temperature. And anterior spinothalamic they cause the mediate the touch and temperature. Sorry, pain and temperature through ventral and touch, crude touch, and pressure sensation are through anterior spinothalamic tract. Yes. So these sensory fiber terminate in the dorsal horn and projects from there, crosses the midline and ascend in the ventrolateral quadrant of the spinal cord to ventro posterior lateral thalamus, and then to a primary somatosensory cortex. So this is the pathway. So you have to remember that lateral spinothalamic tract carries pain and temperature, whereas anterolateral pathway carries the crude touch and pressure, whereas the fine touch and proprioception is carried by the dorsal column lemniscus pathway. Okay, so management of pain, WHO ladder, analgesic ladder, initiate peripherally acting drugs such as paracetamol and non-steroidal anti-inflammatory drugs and SAIDs. If pain control is not achieved, the second part of the ladder is introduce a weak opioid such as codeine or dextropropoxyphene, together with the appropriate agents to control and minimize the side effects. The final rung of the ladder is to introduce strong opioids such as morphine. Analgesia from peripherally acting drugs may be additive to that from centrally acting opioids, and thus two are given together. For example, you take one week and another paracetamol, so they can have additive effect. So you can use them together as well. So this is WHO ladder. Peripherally acting drugs like NSAID, paracetamol, then weak codeine, opioids, and then strong opioids. And then we have the blocks, local anesthesia and the blocks. The World Federation of Societies of Anesthesiologists analgesic ladder. So one is WHO ladder, and this is the anesthesiologist ladder. Okay, I think we need the video as well. Okay, so for the management of acute pain, initially the pain can be expected to be severe and may need controlling with strong analgesics in combination with local anesthetic blocks and peripherally acting drugs. The second rung on the postoperative pain ladder is the restoration of the use of oral route to deliver analgesia. Strong opioids may no longer be required, and adequate analgesia can be obtained by using combination of peripherally acting agents and weak opioids. The final step is when the pain can be controlled by peripherally acting agents alone. So this is almost the same thing, that you can have the peripherally acting alone, and then together with a strong for the additive effect, or when the pain is very severe, or you can say that immediately after surgery or trauma the pain is severe, so you go for blocks and local anesthetics and strong opioids, and then after we can use strong opioids and locally or peripherally acting drugs like NSAIDs together and then only NSAIDs. So this is in opposite direction. Okay, so there will be another video, so part 2 will be recorded.